Imagine secretions so thick and so sticky that they're almost like honey. Now imagine your clients trying to breathe through those honey-thick secretions, lining their lungs. Hi, I'm Krista, and today we're talking about the slow, sticky secretions of cystic fibrosis. So what is cystic fibrosis? Well, it's a progressive, incurable genetic disorder that significantly affects the respiratory and GI systems and decreases overall life expectancy. This is an autosomal recessive condition, meaning you need one gene from each parent in order to get this condition. So essentially, this is a dysfunctional exocrine gland. Specifically, it's the CFTR channel that transports chlorine and water on this exocrine gland, like in the respiratory tract. So in a normal airway, we'll see that chloride and water can freely move outside of the cell and bin those respiratory secretions. But in a dysfunctional CFTR membrane, that chloride and water cannot leave the cell, and therefore those respiratory secretions become really thick and sticky. This leads to copious, thick, sticky mucus in multiple organ systems. That leads to organ obstruction, and it causes things like obstructive respiratory disease and GI obstruction. This is diagnosed through family history, genetic testing, and an elevated sweat chloride test. So those dysfunctional CFTR channels are also in the sweat glands, leading to super salty sweat, and that causes that elevated chloride test. When you think cystic fibrosis on your NCLEX, I want you to think slow, sticky secretions. So those slow, sticky secretions can affect multiple organ systems, including that respiratory tract. So it obstructs the bronchi and leads to air trapping and atelectasis, as well as because those secretions are sitting there, bacteria can grow super easily, so it leads to respiratory infections. Commonly, we will see frequent infections like bronchitis and pneumonia in these clients. Also, because those secretions are really thick and hard to clear, we'll see chronic coughing and wheezing because of that airway obstruction. Because this obstruction is chronic, it can lead to signs of chronic hypoxemia like barrel chest and fingernail clubbing. So those same slow, sticky secretions can also affect the GI tract and the intestines, and that can lead to intestinal obstruction. So in the GI tract, in our newborns, we will see this as a failure to pass meconium, that first poop, and that is usually the first warning sign of cystic fibrosis. In our older kids, this will appear as intestinal obstruction. Then that same slow, sticky secretions can obstruct the pancreas and cause pancreatic ducts to be full with secretions and to block the release of digestive enzymes. This leads to malabsorption of those fats, carbs, and proteins. So we will see these clients will have malnutrition and growth failure. Lastly, because they're not getting a breakdown of fat, the fat will stay in that stool. So it will appear bulky, frothy, foul-smelling, and called steatorrhea. We'll see other effects in other body systems, like that salty sweat from that defective CFTR channel. Often when the parents will kiss their child, they'll notice it's salty, and that's another early sign of cystic fibrosis. Then that same slow, sticky secretions in other areas we'll see in the reproductive system. So it will make it hard for that sperm to meet that egg, and it can lead to infertility. This is our first quick check. Take a moment to answer. What kind of stool is seen in clients with cystic fibrosis? Well, remember those slow, sticky secretions in the GI tract. That leads to malabsorption of fat. That fat then stays in the stool and it becomes bulky, frothy, and foul-smelling and known as steatorrhea. Remember, this is the same reason we have obstruction within the intestines, and that causes that delayed passage of meconium, that first warning sign of cystic fibrosis. In order to address all the problems caused by those slow, sticky secretions, our nursing care needs to focus on respiratory support, GI support, and psychosocial support. We prioritize that respiratory support because we don't want those thick secretions hanging out in that airway and causing an infection like pneumonia. We need to think about how to get those secretions out, like getting honey out of a jar. So we need to think about how to thin those secretions and mobilize them so the client can cough them up and out of that airway. In order to mobilize these secretions, we give inhaled medications like bronchodilators like albuterol and mucolytics like hypertonic saline. And remember, with hypertonic saline, that water follows salt. So that water will be drawn into those respiratory secretions so that they're thinned and more easily coughed up by the client. But when the NCLEX asks you which to give first, what do? We give that bronchodilator first. Why? Because it opens up that airway so that when we do give the mucolytic, that passageway is clear for the client to cough it all up. Then we perform daily airway clearance therapies, or ACTs. These are things like chest physiotherapy. That is when the nurse or respiratory therapist uses cupped hands to vibrate the chest wall and percuss it so that we loosen those secretions. This can also be done by a high-frequency chest compression vest like we see here that delivers the same vibrations to the chest wall. Then we can also see postural drainage. That is when we turn the client and elevate them in certain positions to allow gravity to get those secretions out of that airway. There's also positive expiratory pressure devices or PEP devices like this flutter valve here. This is something that the client blows into to create back pressure into the lungs that loosens the secretions. And it looks and sounds like this. Lastly, we'll see huff coughing, which is similar to positive expiratory pressure, and it creates that same pressure to help loosen that mucus. This is also done with our COPD clients. Another timing consideration that you need to know for the NCLEX is that we want to avoid performing these ACTs immediately before or after meals. Well, this seems obvious because banging on them or causing them to be elevated or turned in weird positions can cause nausea and therefore vomiting. So we want to avoid doing it around mealtime. So remember the order of these interventions. We give those bronchodilators first to open that airway and make that passageway really clear. Then we give mucolytics to draw water towards them to thin them out. Lastly, we perform those ACTs to help loosen and mobilize that mucus so the client can just cough them up and out. Those slow, sticky secretions can breed that bacteria that leads to those nasty respiratory infections. So to prevent infection, we need to encourage immunizations and hand hygiene. Clients with cystic fibrosis often have their respiratory tract already colonized by super drug-resistant bacteria and viruses. So they need to avoid close contact with other hospitalized CF clients because they can more easily spread those serious respiratory infections to each other. We need to immediately notify that healthcare provider for signs including respiratory infection that can be seen with subtle signs like decreased activity and decreased appetite, and pneumothorax, because long-term lung damage can cause blebs on those lungs, and if those blebs pop, it can lead to a collapsed lung or pneumothorax. So our next quick check, take a moment to answer. What should be done first? Give the client a bronchodilator or perform airway clearance therapy? We always do the bronchodilator first because it opens that airway to make way for those secretions to be coughed up. Then what subtle signs can indicate a respiratory infection in these clients? Well, those are subtle signs like decreased activity and appetite. So remember, those slow, sticky secretions cause that obstruction and decreased nutrient absorption in the GI tract. So we need to support nutrition. We need to promote high protein, high calorie, and unrestricted fat diets. This is to offset that malabsorption, and because they have increased metabolic demand, because they have those respiratory secretions in the airway that cause increased work of breathing. We encourage increased salt intake and increased fluids during hot weather and exercise, like during physical education class in school. This is because of that defective CFTR channel that causes them to lose excess salt through that sweat. Because those pancreatic enzymes were blocked from those secretions, we need to replace that lipase, amylase, and protease to break down those fats, carbs, and proteins. So we give pancreatic enzyme replacement therapy, or PERT, which is these enzymes in a capsule form. And important on your NCLEX, Give them within 30 minutes of eating. This is because this is around when they're normally released in the body. So as a nurse, we want to deliver these with a meal tray and have them take it with their first few bites of food. We do not crush or chew these capsules because it can destroy the enteric coating and decrease their effectiveness. We give those fat-soluble vitamins like A, D, E, and K because they have that decreased fat absorption, so we need to supplement with extra amounts of these. For other GI support, we monitor for those nasty complications from those slow, sticky secretions. We need to immediately notify the healthcare provider for signs of GI complications like intestinal obstruction that can be seen with abdominal pain or distension. Remember, those slow, sticky secretions in the pancreas can build up and cause pancreatic damage, and those can damage the cells that produce insulin, therefore leading to diabetes mellitus. Cystic fibrosis is an incurable and progressive illness that can cause stress and can disrupt normal childhood development. So we need to provide psychosocial support. We do this by connecting them with community resources like the Cystic Fibrosis Foundation that provide emotional and financial support. As nurses, we want to encourage physical activities like sports as tolerated. Not only does this improve lung function, but it helps support normal childhood development and allows for socialization. We want to address fertility and childbearing concerns because remember, this can cause infertility. For our last quick check, take a moment to answer. What diet and vitamins are best for cystic fibrosis? Well, remember, they have that increased metabolic demand and that malabsorption. So we want to give high-calorie, high-protein diets with vitamins A, D, E, K, those fat-soluble vitamins. We give extra to make sure that they have enough. Which medication is taken within 30 minutes of eating? Well, remember, they're having that malabsorption, so we need to replace those digestive enzymes that they're not getting, that lipase, amylase, and protease, so we give that pancreatic enzyme replacement therapy around meals to maximize absorption. Then what kinds of activities should the nurse encourage for clients with CF? Remember, we need to encourage physical activity as tolerated. That helps improve lung function, it supports normal childhood development, and it allows for socialization. Now you've mastered cystic fibrosis for that NCLEX.